Admitting all now.
Great, thank you. Lovely. Welcome everybody to this exciting webinar. Firstly, I'd like to acknowledge the traditional owners of the land, of elders past and present, upon which we all collectively stand. I think we all agree that in our health system, surgeons play significant leadership roles across the board. And given the pandemic and then the constant rate of a constant state of staying alert in this crisis, their ability to be effective leaders rely firstly on timely information, having some sort of visibility on the strategies in terms of health decisions, and of course extensive collaborations, both state and federal, I think. So with that spirit, we thought we'd pull this webinar together. I'm extremely grateful for our speakers who've managed to free up their very valuable time. To begin with, just a little bit of housekeeping. If you could, for all the speakers, so for all the, everybody except for the speakers, if you could please mute your audio and video. Please feel free to put questions on the chat. If we run out of time to get through all the questions, we certainly will be able to email you back with answers. And we are recording this webinar, so if you have to leave and you're going to miss out on any part of it, then we certainly will be able to send it to you later on. So with that, I'd just like to introduce our speakers. Now, our speakers don't need any introduction. However, it's not common that we actually have the ability to look at the background of the people that we know so well. So firstly, I'd like to introduce John Biviano, who's our CEO. He's been our CEO since 2019. John's had over 30 years of health experience and over a decade of experience in health leadership. And he's been a remarkable leader and extremely passionate about many areas, including sustainability, Indigenous health, patient outcomes, and building respect in surgery. Nick Coatsworth is well, I can't imagine that anybody is not familiar with Dr. Coatsworth, who's we've become so accustomed to listening to his measured and sensible health advice on media. Some of you may know him and have had the good fortune of working under him as his intern or resident from many years ago in North Shore. Nick is not only a respiratory physician, he's also an infectious diseases specialist, and he has extensive experience working in health emergencies. And we're extremely grateful for the collaboration and help and advice that he's provided at the college throughout the whole extent of the pandemic, and hopefully will continue to do so. Last but not least, Susan Pearce, who's the Deputy Secretary of Patient Experience and System Performance at the Ministry of Health in New South Wales. A nurse and lawyer background, Susan has extensive, she works tirelessly to fight emergency responses, and she's been such a source of good advice and help for the State Committee. She works around the clock, which I know because I reach out to her at all hours of the day, unfortunately. But I'm very grateful for her also being able to free up a time, and look forward to her sharing an insight into the work that she's done. So without further ado, I'd like to start off by getting John to share with us his insight. Thanks, John.
Thanks, Payal, and for the opportunity to join you, Nick and Susan, and everyone on this webinar. I'll just spend a little bit of time just talking about the importance of RACS and our 9 surgical specialties as we work together as one college. And that's particularly important as we collaborate, particularly in terms of what's happening at the moment with COVID-19. That's really, I think that's brought us all together as one college, and those strengthened relationships are really important across all levels, whether it be fellows right across the college and also staff as well. And what we see happening, you know, and I'm sure you'll agree, is that we're getting improved outcomes through this mutual collaboration. And so that's been a major strategic direction over the past 3 years. And as you be aware, it's so important to get those relationships right across so many surgical specialties. Even though there are the 9 key specialties that we train in, there are also other subspecialties, which are many and varied. So I guess it is important that we reiterate the fact that RACS can facilitate those relationships and those collaborations, which is really important. Just really as a binational college, we're mindful of our obligations across both Australia and New Zealand, as well as across all Australian states and territories. And today's focus is obviously New South Wales. We've spent a lot of time and energy trying to ensure that we get the internal relationships right across all our various Australian state and territory offices and committees, and New Zealand offices and committees as well. And our work with government at both federal and state level is something that we continue to do to influence key decision makers, always with the intention of ensuring we have the highest quality surgery and healthcare system. So in terms of just with those introductory remarks, I mean, with the COVID-19 approach, that's been really important for us to really lead as we did. It's almost 6 months. I can't believe how time has gone past. 6 months since we cancelled all college activities, and that was a huge decision, as you can imagine. And here we are now in the, I'm from Victoria, and we're in the second wave of the pandemic. It is pleasing to see the numbers starting to come down, so that's really great from our point of view. But I guess our key motivation has been to promote safety for all our RACS people, including all our fellows, trainees, SIMGs, and our college staff and broader community. So our emphasis has been on assisting and supporting our fellows, our trainees and SIMGs. And right from the start, it was about achieving clarity, particularly for our trainees around courses and exams, which has been a major emphasis. And obviously, as you can imagine, a fairly stressful time for that particular group, particularly the ones that need to sit their fellowship exam. Moving over to COVID, there's a lot of information on our COVID-19 hub, and I'd just like to remind everyone, hopefully you've had lots of reminders, but it is an important source of information with a lot of general and specialty specific resources. In terms of elective surgery, as you'd be aware, we were instrumental in the cancellation of that elective surgery, obviously in close collaboration with government. And now we're faced with, the ramping up in various jurisdictions, which has been quite challenging and controversial and the subject of today's webinar. Just moving over, with collaboration with government has been really vital, and we really value our relationship with Nick, who's on this webinar with us. And certainly we're there to help as much as we can. And I know Nick is in constant communication with our president, Tony Spahn, and that's been really helpful for us as an organisation to have that relationship with Nick. State differences have proved a bit challenging, as we all know, and that's something that we're working through. And again, we value those relationships with all the state jurisdictions, and it's nice to have Susan with us here today. I guess just to think back, we've had previous video conferences with Nick and our specialty societies, which have been really informative, particularly around the range of issues that we're talking about today. We also had a webinar earlier in April. And I guess I just want to re-emphasise the fact that we can engage with our specialty societies. Those video conferences that we had with Nick were with all the presidents of the 9 key specialty societies, which were really important in terms of talking about PPE, availability and so forth, which has been really important. I just want to say that we're very conscious of the impact on the private sector in particular. I mean, obviously the public sector has been affected, but there are particular sectors that have been affected more than others, and the younger fellows that have been affected. Certainly, PPE has been a huge issue for all our members, and I'm sure Nick will talk a lot more about that, so I'm not going to steal your thunder, Nick, by any means, but certainly that has been the subject of many discussions with us, particularly for high-risk procedures, which we'll get into as we go through. I just also want to reiterate the work that ASINEPS has been doing, so our research arm in Adelaide, and the various rapid reviews that have been produced, and they're all available on the COVID hub. We've got reviews that deal with surgery triage in relation to COVID-19. There's also guidelines for PPE and many others. So during our last discussion with Nick and our specialty presidents, we talked quite a bit about PPE, which I guess is, you know, obviously uppermost in most of your minds, the timeliness of the supply, the variation, the type and the fitting and so forth, which is really important as we get back, you know, to surgery. Importantly, we also talked about the issue of having really good guidelines across this, which is really important, and also looking at community prevalence and transmission in terms of that, how that guides our operations, which, as you all know, is really important in terms of the risk and how that affects where operations take place and so forth. Pre-testing was discussed as well, and I know that that will be something that Nick will talk about. So I'd just like to end up just by saying that you know, we are very conscious of the ramp up now with elective surgery happening, and also the need to come up, something that has come up with the specialties has been the need for a more comprehensive and sophisticated approach to determine elective surgery. Not just the current categories 1, 2 and 3, and I will welcome some more conversation about that, and certainly what some of our fellows are calling to, and certainly the specialties were saying we need a much more sophisticated way of assessing who to operate on, and in some cases, you know, I think the old category system perhaps is not fit for purpose anymore. I'm also pleased to advise that RACS now has representation on the National Clinical Evidence COVID-19 Task Force, which is really important about having input into COVID-19 related issues. And our representative there is Professor Mark Frydenberg, who's a counsellor and urologist, and he's the chair of our research and academic surgery area. So that's really pleasing. So I'd just like to end on, I mean, I guess the best way we can beat this pandemic is by working together. And I, together with the team of RACS, am very happy to facilitate that. Obviously, we need to ensure that the safety of healthcare workers, patients, and the community at large comes first. Thank you.
Thank you so much, John. And you know, it's fantastic to see that everybody's working together, and you know, certainly agreed that just working together also at a state and federal level, because we've had to be quite agile in terms of how we make those decisions for surgery, is fantastic. So with that, I'd really love to invite Nick to give us his insight into how things are panning out.
Thank you, Payal. Thank you, John. And I really appreciate the invitation. I'm got a short amount of time, so we can facilitate questions. So I'll talk about 3 things. I'm actually really pleased to be able to give you some preliminary results from the asymptomatic surgical screening study that we commissioned from surgeons and anaesthetists around the country, and then I'll discuss a little bit about PPE guidance and some of the rub points between federal and state guidelines, or at least why they occasionally appear to exist, and what we might do about them, and then just go into the future of COVID, a brief comment about that. So when the first wave was occurring, and the fact that this virus has a pre-symptomatic period, there was a significant concern, I don't need to tell you, from those involved in the operating theatre environment, surgeons, anaesthetists and operating theatre nurses, about the potential for someone to slip through the risk management net and be an asymptomatic person undergoing intubation, and the operating team was not adequately protected by personal protective equipment. So as those numbers came down, we undertook, with the sort of endorsement of RACS and ANZCA, to perform a fairly large-scale study of patients who were undergoing elective surgery who were asymptomatic. And based on the prevalence, the estimated prevalence numbers at the time and the sensitivity of the test, we calculated that we needed to recruit 3,000 patients between May and, it was between April and July 17 was when the study finished. Now, we recruited from WA, Victoria, New South Wales and Queensland. Some of those states had variable prevalence, and at least in Victoria, we can be reasonably confident that there was ongoing community transmission at a low prevalence level. But the preliminary results are back, and out of 3,000 tests that were conducted, none of them were PCR positive. And I think it was only a handful, maybe 2 or 3, were serology positive. So that was quite comforting in terms of, you know, it sort of debunks this idea that there might be a large, you know, bit under the iceberg that we're not actually seeing, and that might produce risk. So when our testing rates are high in the community and we're not finding many cases, as is the case in New South Wales and Queensland at the moment, the risk to the operative team of an asymptomatic patient coming through the door with COVID and getting intubated is very, very low indeed. Now, fortunately, because that study was ongoing as Victoria went into the second wave, Paul Miles, who was one of the chief investigators, was able to negotiate with Vic DHHS to continue that study. So the next phase of our reporting will actually be the prevalence of asymptomatic surgical patients testing COVID positive mapped against an epidemic curve in Victoria. So it's going to be really important data, and we're going to work quickly to get that out as soon as we can. But I can tell you, obviously, it wasn't zero. There was, I think Paul mentioned it was about 1 in 500 was the risk or the prevalence of COVID-19 in asymptomatic patients undergoing surgery. So this has policy implications, of course, because there has been, it's about when do you start preoperative testing. There is not only a healthcare worker safety imperative, but we now know from Australian and international work that there is a morbidity and mortality effect of conducting elective surgery in patients who are COVID positive. So that's on the for side, but on the con side, you've got an increased testing demand, quite a substantial increased testing demand on your testing infrastructure. And we've seen what happens in Victoria. There are limits to any jurisdiction in Australia as to how quickly they can process tests. If you put a lot of burden on the testing system, the length of time between test and result starts to increase, the frustration in the community starts to increase, and people go out of isolation and the epidemic gets worse. So this is the public policy decision where you have to balance, well, are we going to invest in what's potentially thousands of preoperative tests, or are we going to leave it with the public health units? And what is the point where we actually want to start preoperative testing, acknowledging that it will have an impact? Now, interestingly, what seems to happen is that you get to a point where you might want to start testing and then the jurisdiction cancels elective surgery because of the burden. So it's not a straightforward area, but and I don't think this study answers every question, but it was really useful. And I just wanted to highlight the support of Tony Spahn and other members of RACS, particularly in delivering the outcomes. And in fact, there's people on this call, I've seen the participant list, who likely were participating because they were at some of the trial hospitals. So that's perfect. And I've already gone over time, so I'm just going to have a very brief chat about TPE. Two things. The infection control expert group, who are they and what do they do? Well, they're actually frontline ID physicians, microbiologists and nurses themselves. They've built a career in the specialty of infection prevention control. They're appointed by the government to advise Australian Health Protection Principal Committee, the AHPPC, and the chief health officers. So they act in an advisory capacity. And all the guidelines that they produce have to be endorsed by the AHPPC. So they've come under a lot of fire recently for whether their expansion of guidelines is correct or timely. But in actual fact, it is the chief health officers that endorse those. So once they're endorsed, what happens? Well, you've still got a fragmented health system. You might use those words, but this is the reality in which we live, and we just have to manage it. So from the New South Wales case, and I'm sure Susan will comment on it, you have the Clinical Excellence Commission, you have New South Wales Health, and you have the advice of Dr Kerry Chant as the Chief Health Officer. And all those then come into the New South Wales decisions about personal protective equipment. And quite rightly, because they bear the responsibility for their employees. So whilst we try and keep things as consistent as possible, where you have different people employing and you have national guidance, but the employers are at state level, things can become a little different. And then finally, there's a lot of individual clinician pressure, and we've seen that play out in Victoria, where some hospital CEOs have been pressured into going beyond the guidelines by some members of their clinical fraternity. Now, that's not helpful either, because when some hospitals, we're so networked at the moment, that when some hospitals see another hospital allowing N95s for all intubations, whereas another hospital is trying to hold the line with the state guidelines, that again creates the friction. So what's been useful is the open dialogue that we've been able to have with RACS and ANZCA in particular, ANZICS as well, where their guidelines have been sent to ICEG for comment, and that's been really good. And in particular, from the RACS point of view, the interaction with ASONS and the Neurosurgical Society, where I've been able to work directly with Seren Krishnan and Sarah Olsen in assisting to review guidelines. And I might stop there because I don't want to hog the floor.
No, that's fantastic, Nick. We've got so many questions for you, but before we open up to questions, it'd be great to, I'm sure Susan's going to be able to fill some of those gaps already. So I just invite Susan to share her wisdom, and then we'll open for questions. I can see some of the questions already starting to come up on the chat.
Thanks, Pyle, and good afternoon to you all. Look, can I start by thanking everyone on the webinar this afternoon for the work during what has been a most extraordinary year this year. It just is incredible, and I think certainly one will never forget, that's for sure, no matter what you're doing in it. Kyle and I didn't know each other before this all started, but we've certainly had a lot of communication since it has, and it's been a very important thing, obviously, from our perspective here in New South Wales, to have very strong engagement with our clinicians and our staff generally. Obviously we have a very large workforce, 146,000 staff at least, headcount. And to Nick's point, in regard to the consistency of messaging around PPE, it's incredibly challenging, obviously, with a lot of entities within the New South Wales health system, not as many as in some other states, of course, but we've really had to rely on our local management teams to make sure that those messages that are coming from our experts are consistent and strong. And, it has all of those comments that have been made around, one hospital doing one thing and another hospital being able to do another have been felt here as well, particularly in the early days. But look, I think, without dwelling on that, I guess as I've touched on, collaboration has been key. I think that silence from, the health service or the health management teams is a very dangerous thing in this environment. And I think that while we were all scrambling at the start to get our information together about what we were being confronted with, the challenge was then how you communicated that to your broader clinical community when there was such a degree of uncertainty. And there's always that level of nervousness from us on the bureaucratic side of the fence about, if we say this, what's going to happen? But if you say nothing, I think that's much, much worse. And so, the myths tend to develop very quickly. We had a degree of confidence about what we were doing, but of course, history was only going to be the judge of that, and will still be the case. So look, some of the things that we've done here in New South Wales include we've always had, and for a long time had, the Agency for Clinical Innovation and strong engagement with our clinicians. But one of my colleagues, Dr Nigel Lyons, has been chairing a clinical council with clinicians right across the system and from different craft groups now for many months. And I think that's been a very valuable way for us also to get information directly out from the centre. As Pyle knows, and with her assistance and also Arthur Richardson, who's the chair of our Surgical Services Task Force, we held a surgical roundtable back in July, and to some extent, it sort of was, it might have seemed like odd timing, but our minister was very keen that we get on with this. And to be fair, look, I think it was a good thing for us to be doing. The reality of it is that we have got to be future looking while we're dealing with all of this, and that's really the challenge, and it's something that Pyle and Arthur and I have talked about a lot, because we're managing staff fatigue. Everybody's exhausted, no matter what job you're in. We're meanwhile trying to ramp up surgery, and, you know, obviously, touch wood, we've been very fortunate here in New South Wales that we've been able to get on and do that. And I'm happy to talk about surgical categorisation further down the track, because obviously that is a significant issue and one that we're also keen to look at. So, you know, ramping up surgery, everyone's exhausted. We're trying to make changes and be future focused, and at the same time making sure that our staff are safe, and if possible, somewhere along the line taking some form of a break. But, you know, it really is very difficult for everyone to even contemplate that. So there's a heap of things that we're thinking about and really conscious of in this. I think that the delayed care and people's decision making around access to care is something we've been acutely aware of. In the early days, and even before the surgery suspension was formally announced, we could see that patients were voting with their feet. And they were doing that because clearly they were scared and worried about coming to hospital and what the prospects of that might mean. We've seen that play out, of course, in our emergency department attendances as well, of course. And you know, I just got the data today on April to June this year compared to April to June last year, saw an almost 20% reduction in emergency department attendances across New South Wales. Now, unfortunately, at the moment, we're back up to basically business as usual. And I say unfortunately because one of the things we're keen to do is to use this crisis an opportunity to make change, and we've got to move quickly to do that in the context that I've just described. So look, briefly, and then I'll stop as well too, because we need time for questions. Our surgical roundtable certainly has produced some things for us to think about. How do we make sure that, particularly for cancer patients and people who may have delayed care during this period, are attended to? How do we correct some of the problems that we were already experiencing with delays in scopes? And that's something that Arthur in particular is particularly passionate about. We're already seeing as a consequence of the resetting of things, we've got our districts thinking about this in a different way. So there are positive things happening. And I guess we've got to give people some hope that, you know, that there is something good that will come out of the pain that we've all experienced as a consequence of this pandemic. You know, the clinicians and the team that came together for the roundtable, you know, none of it's rocket science. None of it is things that people wouldn't expect to come up with, and including how we think about how we best use the resources available to us in both the public and private sector to get surgery done. And as I said, at the moment, we are firing up on all cylinders trying to get this work done. We saw very quickly the number of patients who didn't get their procedures and surgeries during that period, something in the order of, I think we ended our financial year this year 23,000 surgeries down from the previous year, all as a direct consequence of this environment that we're in, and that's a lot of catch up for us to do. Meanwhile, making sure that what we're doing is appropriate. So no small undertaking, but I'll stop there, Pale, to make sure people have time for questions. Thanks.
Yeah, I mean, I think it's no small undertaking, and then now we're sort of getting into a phase where we're getting into burnout because people are doing 6-day weeks, and in the fear, this looming fear that if numbers, suddenly peaked up, as Nick alluded to, that we might have to again close down, and we hope that doesn't happen. So we need to be prepared for that as well. I suppose looking at the questions coming through the chat, probably a real issue is the categorisation. The fact that there's nothing really between 2 and 3. There's a big gap between 2 and 3, and that covers a huge spectrum of patients with different morbidities. And the conversation we want to have is, how do we reduce that morbidity? Looking forward, planning forward, what are the strategies that we can put in place? So I'd love to hear from you first, and then Nick, about what we can do together to help encounter that.
Look, thank you, and thank you for asking that question, because as we've discussed, I completely agree with the challenge that the categorisation presents. Now, it would be easy for me to say that it's a clinical decision around how patients are categorised, but ultimately here in New South Wales, the great bulk of our surgical workload is in Category 3, as you know, and obviously states, whilst there is some level of consistency, there's also a great degree of variation as to how that occurs. And we know full well that there are patients who can be a Cat 2 patient and safely wait for the 3 months. But Cat 3 patients, the span of a year is a long time, and consequently, clearly there is room for us to think about how that could look going forward, and whether there are subcategories or how we contended with that. The one thing I will say though is this: one of the challenges that it presents is that we've got to be careful that we don't swing the pendulum too far. So I think this is where the appropriateness and the issues around futile care really need to be challenged and addressed with our clinical community. This is not a bureaucratic decision. This is a decision that we've got to come to, I think, as a group, because if we swing that pendulum too far and we end up with a situation where people are made in a great number, given that, in New South Wales, our system was funded to do 230,000 elective surgery procedures. In the last financial year, it'll be something a little more than that this year. On top of that, we do 100,000 emergency surgery procedures, and then all of that other work that nobody counts with scopes and the like. So there's a very large volume. If too many of those people are made urgent or even semi-urgent, then it reduces the amount of flexibility that the system has to be able to bring urgent patients on when they need to. So I just put that there, not as a shield or to suggest that there's not room for change here, but it's very important that we contemplate unintended consequences, because when you pull one, I've learnt this the hard way over the years, when you pull one lever, something else will happen that you may not have been expecting. But, we are very open to thinking about how we can do that better here. And it would be great to have some national consistency, to be honest, in regard to that.
Yeah, you certainly don't want to have, categorisation change in one state and not in the others. Nick?
Thanks. So this has been raised since we first started talking about this shutdowns and so on and so forth in the first wave. I think I'm not going to spend too much time on it, because it's going to be it's not particularly the area of the expertise of the CMO's office. But I want to take on board exactly what Susan and Pyle just said, that there might need to be a national approach. One of the challenges with the national approach at the moment is we don't have the old COAG committees anymore, and so it really needs to be done, I would have thought, not in the public health sort of technical space, which is where the CMO's office sits at the moment, but in what used to be the RMAC space, the Australian Health Ministers Advisory Council. So I can, it'd be interesting to take that forward and see what organs exist within the Department of Health to sort of push that issue forward. But from this is for John. I mean, I think what the pandemic has shown is that the Federal Department of Health does have more room to take some leadership on what, or at least get consensus on what have traditionally been thought of as state issues. And we don't want to interfere with states, but we want to work collaboratively. And having someone who, as a CMO, who is cognizant of hospital issues, I think has been valuable, and is a new thing. There hasn't been that, and we can. Unfortunately, I was taking notes as Susan spoke because I'm going back as a senior administrator at Canberra Hospital on October the 12th, so I'm going to need to manage all these things.
Thank you so much. I just want to, I was going to raise a question about cancer screening, and I noticed that there's a comment on the chat about a decline in 20% of treatments in public and private breast cancers from between April, May and June. So I suppose this is, and both to Nick and Susan, in terms of what can we do looking forward, say if there is shutdown again in New South Wales, and what can we learn from Victoria in terms of being able, or even from the first peak, is there data from the first peak where we can effectively manage those conditions and prevent disease progression, particularly when it comes to screening for cancer?
Susan, did you want to go first? I can. If you,
yeah, go ahead.
Yeah. Thanks. So I think overarching is the communication to all patients, and that can come from the federal level, amplified within the jurisdictions. That and we do constantly try and do this. We've got to understand better why the message isn't getting through as effectively. But these things don't wait, and the screening programs are open for business. So this is something that can be raised with the various peak groups that we interact with at the federal level, and we just need a better communication strategy, I think. But to say that we haven't been doing it, I think maybe we haven't been doing it as effectively as we should have been. But it's been a constant message since about April that people need to get out there and attend to their own health needs. Some of this will be, people talk about the HIV pandemic a lot, epidemic, and I was a young lad back then with the Grim Reaper ads, but the behaviours shifted as people became more comfortable with things, and with time, people will become more comfortable with COVID, both clinicians and patients. So we may to an extent have to wait for that, but we certainly won't be waiting in terms of strategies to try and get people to get their preventive medicine done.
Susan?
Yeah, look, I agree with what Nick's had to say. I guess the point for us now is that we do need to think about the learning. So, if you go back 6 months or around that period, there was clearly, and there still is to some extent, some very large extent, a great deal of fear around it. And from the clinical side, an incredible amount of fear, because obviously we're seeing vision of, Italy and Spain and the like. And so that got translated into this is what's going to happen here very quickly. I think, back to my earlier comment, emergency department attendance has just dropped off a cliff. And that wasn't because people stopped getting sick. Now, they just stopped coming in very, very large numbers. It is, the drop is actually more significant because some of our numbers from that quarter actually include, COVID testing. So if you really drilled into it, it would probably be more like, 30 or 40%, I would say, at a point in time there. So I think the comment about people will get more used to this is right. I think that what we're trying to educate the public here, through Kerry and our Premier, is that we have to learn to live with this thing, at least for now. And I suppose we're trying to do that to some extent, but also for our clinical stuff. So, breast screening was stopped during the slowdown of things, and I remember being provided a number as to what the quantum was of women who had then, what the catch-up was. It was just breathtaking. in a very short period of time. So, you know, we know a lot more about this now. We know what's worked. We're confident with regard to, for example, our PPE supply. I think our staff are more, you know, to a large degree, I'm not saying it's perfect by any stretch, but, you know, there's a greater degree of confidence around the management of the pandemic, and we need to use that confidence to also instill that confidence in our community. It is challenging because, you know, you're balancing that we need to manage this. This is a, you know, a very difficult pandemic to manage clearly against we've got this. And I think that's the difficulty in the messaging.
Paul, can I just pick up on something that Susan said, particularly with regard to breast screen? I mean, it's a very good example because I remember this being discussed at the HPPC, and around the table, most of us were sort of thinking we don't need to stop this, and it was driven by the breast screen folk themselves. Now, that's not a criticism; that's just the reality. But the effect that does have an effect on patients, and so what you'll see from government and policymakers, I suspect, is people being a lot more circumspect about those decisions if there's a second wave. Just as Victoria was much more circumspect about cancelling elective surgery and actually waited for a fair while before they did it, because, you know, there are consequences to those decisions, including and probably foremost the way patients are viewing the safety of the service.
Thank you. The other question I had was about, I suppose with New South Wales, it's kind of a cluster based, and that cluster keeps changing. And that's one thing in terms of being able to be agile, because where there is a cluster, you have to have a higher degree of vigilance. But the other thing is that as the clusters grow, we're sort of losing track of what is not a cluster anymore. And certainly something that we're seeing, particularly for patients coming to metropolitan Sydney from the country to access, say, cancer care or other services, is they're kind of, you know, there's this label of Sydney being this hotspot, because we don't really know what is not a hotspot anymore. It's just easier to label it. And that's really impeding. And what can we do, impeding people's access to care, because they're just scared to come. What can we do to improve that? What would you recommend? How can we have better clarity of what is safe once it's been unsafe? Susan?
Look, I mean, it's a tricky one, Pale, because the reality of it is, and look, I can only speak from our experience here, and if Kerry was here, you would get a scientific answer to all of this. But look, I think it's fair to say that even where the clusters have established, what we're tending to see is, even if it takes us a little while to catch a few that appear and pop up, that are unlinked, most often it's like, oh, okay, and we're linking them to those clusters. So if I think about, you know, the most recent scenario here, you know, starting with the Crossroads Hotel, you know, for us here in New South Wales, after we were sort of, you know, we felt like we were humming along pretty well with the community transmission. Now, the Crossroads Hotel outbreak is a remarkable story to the extent that we had a patient in Nepean Blue Mountains who was diagnosed with COVID. We had a female who attended one of our hospitals. She was pregnant. She was about 32 weeks, I think, from memory or something like that. Turned up at the hospital, not feeling particularly well, but not, you know, a typical COVID patient. And the obstetric registrar thought, look, I'll just do a swab while she's here. And bingo, she was positive, but they had both been at the Crossroads, and that was the key to us finding that cluster, which we then responded to very, very quickly. So, look, I mean, it's a challenging one and I, you know, look, as you know, Pale, I am a country girl, and I grew up in the country and I worked in Broken Hill for 10 years. So I understand, I'm getting very old and feeling very old at the moment, but the reality of it is that country people do think that this is a city problem. And it, you know, the reality of it is, you know, we've got a case today out in regional New South Wales that's popped up. I'm confident we'll find a link somewhere. But all we can do, I suppose, with our community, and I think, look, Kerry's been exceptional, as you all know, in terms of her public messaging, is keep reassuring the community that the speed of our contact tracing and our ability to identify people who seemingly look unlinked at the start has been pretty extraordinary. There is no simple solution for how we make life easier for people in terms of the movement into the metropolitan area, because at the moment, of course, you know, like a lot of states, we're landlocked here in New South Wales. No one wants us anywhere. And so what we are finding is that people are travelling around within the state for recreational purposes, because, you know, they've got to do something to get a reprieve from this. So, look, you know, it just comes back to communication, and I don't know if people have got ideas about how we could do it better, or how we could get some better cut-through messages. We'd obviously be happy to hear it.
Nick, yep.
Just a quick one. I mean, I think that individual clinicians can use the surgical prevalence study as a really good example for patients. That when we are talking about a handful of cases with high testing rates, there is no iceberg underneath, and it is safe to come into Sydney. So, you know, there's I think New South Wales Health has done a fantastic job, as Susan said, with its messaging, particularly Kerry's clarity of messaging. But at an individual level, we've now got data to suggest that you know, with small cases, our hospitals are safe places. And going forward, we just have to make sure that we keep them as safe as possible. That was going to be my future COVID comment. We are going to have to look at the whole system of personal protective equipment, of risk controls, and so on and so forth, so that we can actually keep the other aspects of the healthcare system going. Because it's we are going to start to get, and we may not have at the moment, we've got a little bit of data, but we are going to start to get the examples, anecdotes, and then the data telling us that there's been morbidity caused in non-COVID patients because of COVID.
So that we've just seen another question come up on the chat, which is a very important one to follow on from that, which is about mental health. And we've talked about crisis fatigue in our staff, and we've also looking at the issue of mental health in the community. And Susan touched on that in terms of, you know, needing to move around in New South Wales. So I suppose the question refers to what is the exit criteria, this is a difficult one. What level of collateral damage are we going to be accepting? So maybe just ask about is there an exit criteria, or better still, how do we make us a more resilient staff and our community, a more resilient community to be able to manage this, because it's not going to be over by a long shot?
That's a really important question, and you know, I think it actually speaks to what in part to what the former Prime Minister raised today, and he did it in a sort of typical way for the former Prime Minister, but raised the issue of how much COVID-related damage are we prepared to have, or how much damage are we prepared to sustain for control of COVID. I think I don't think it's clear that at the moment the national strategy is to use test, trace, isolate to move towards zero community transmission, in the expectation that 2021 will bring either a partially or fully effective vaccine or some sort of treatment. And there are literally proposed treatments coming across our desk every single day. And I'm sure that one of those is going to prove to be some sort of blockbuster. We don't have it yet. But, you know, we are in a unique position as an island. and we're going to take advantage of that to try and suppress aggressively down to no community transmission. Now, what can we do to improve resilience of staff? Well, we can't sustain crisis mode forever, and I think now's the time to move from crisis into business as usual. And as an ID physician, the first thing I'm going to say is we have to find ways to force multiply our infection control professionals to be able to deliver high quality infection control training across the whole hospital. Just give you one quick statistic. It's not a definite statistic because it hasn't been released yet, but if you look at Victoria and you look at the number of ICU docs and nurses, theatre docs, nurses and anaesthetists and surgeons, and compare those numbers of COVID healthcare worker cases, very, very, very low. So, you know, and it's what I can tell you is it might be about N95s, but I don't think it is. I actually think it's about controlled environments and familiarity with PPE and systems and processes that surgeons and anaesthetists and intensivists and the nursing colleagues are very, very familiar with. So if we want to become more resilient, we have to turn our attention to the wards. And, you know, as late as December last year, I was doing ward rounds. Every time I used to do a ward round, I'd point at the overflowing yellow gown bin and say to my registrars, if we have a pandemic, we're in real trouble. And that's why. And lo and behold, it's a pandemic, we're in real trouble. Now, that's not I told you so. That's where the issue is. It's the same with residential aged care. So if we want to build resilience in our hospitals, we've got to look at our EDs and our wards and make sure that our healthcare workers put the same systems and familiarity in place as people in theatres do.
Susan, thank you so much. That was great, Susan.
Yeah, look, I think, you know, we were contemplating today how we perhaps, you know, release some areas, if you like, and that's probably, you know, for want of a better word, in terms of, you know, some of the requirements that we're asking of people around even, you know, PPE use, where there has been absolutely no community transmission for months and months and months. So if you look at some parts of, or many parts of New South Wales, you know, north of, say, Newcastle, for example, we haven't had a case for many months. Now, the question then becomes, how do you, you know, sort of almost set people free of it while maintaining the vigilance? And I think our decision was, we just can't do that yet. It just isn't time. And I think, again, I think I made this comment earlier, we do need to give people hope. And what does the end of this look like? You know, we know that, and I can see a comment there as well. You know, we have never talked about zero community transmission here. We've continued to talk about the suppression of this disease going forward. But how do we give people hope? Now, you know, again, and I sit through our Cabinet Crisis Committee meetings every week with Kerry and my secretary. She's always been very clear from her public health perspective that this is not just about suppressing the pandemic. Public health is a broader issue than the pandemic. It's about the loss of livelihoods. It's about the mental health issues, etc. And finding that balance for us is really the key to continuing to move through this. And, you know, listening to some data today, I know that they're talking about the economic outlook for Australia. The economic outlook for countries, I mean, it's you know, not great in terms of what the numbers are showing. But if you look to places like the UK, it's 3 times greater. And so that challenge of, you know, giving people hope, not letting the reins loosen too much, trying to have people go about their daily lives with COVID-safe practices is really what we're trying to do here, you know, and it is challenging. So I'm hopeful that as we move into the spring and summer, that we can keep our suppression strategy going strongly and let people go about their lives, because really at the end of the day, that's what we need to do until, as Nick says, we have that magic day where we have a vaccine or a treatment for this thing.
And I just wanted to acknowledge the also the numerous frontline workers working in contact tracing, etc., who are working to suppress that. I'm sure that they also have crisis fatigue creeping in, but I just really wanted to acknowledge the fantastic work that they're doing that's allowing us to continue to do our work safely as well. But then I suppose that brings us to introspective and a question for John in terms of if he can reflect on what we can do as a college to also build resilience and continue to be a positive influence in the space with it for our fellows.
Yeah, no, thanks, Payal. Yeah, look, and take on board all those comments. It is a difficult time, and I guess what I'm hearing a lot from our fellows is how do we actually support them, and how do we support them with guidelines and standards about, you know, how they need to manage through this. And that's certainly been a constant thing in terms of how we do support our fellows as well as other healthcare workers out there. So, I mean, we're very keen as a college to work very closely with all levels of government, as we have been, to look at ways we can do that, because obviously people are wanting more certainty, they're wanting more clarity, obviously, and I know it's been difficult, but the more we can do that, the better. And that helps people to adjust and be able to cope with what we need to cope with the virus and so forth. And, you know, an example is with the elective surgery categorisation. I mean, we'd be very happy to assist in any way we can as a college with looking at that, because I think that's a really important issue and certainly something that's come through fairly strongly. You know, is there a much better way of doing this? Which, you know, take on board your comments, Susan, which are really important around low value care. But I think there are ways that we can do that, which are a lot more sophisticated. So we're very, very happy to assist in any way we can as a college through all our different collaborations. Thank you.
Yeah, agree. And I think, you know, going back to something that Susan mentioned earlier is, and that was sort of the spirit in terms of this, why this webinar was organised, is information, to be able to disseminate the information, to know that you know, this is an evolving area, but we are, you know, everyone's working together to achieve the best possible scenario in a worst possible crisis is the most important. I know we've run out of time, but we do have a fair few comments and questions, and with the speaker's permission, I'd love to be able to email them through and love to get your input on those offline, which then we can disseminate to the people putting up the comments. So if that's okay, I'd just like to finish off by firstly thanking both Lauren and Alan, who have also, well, firstly, thank you to all the speakers, but I really wanted to, for all your input and, you know, making your valuable time available, but I really want to also acknowledge the hard work that both Lauren and Alan from the RACS committee have put forward in pulling this together, and just making sure that all of the speakers have had their information and links and everything available. So thank you, everybody. Hope you have a lovely afternoon. And I'm sure we'll continue to talk offline.
Thank you.
Thanks, Payal. Thanks, everyone.
Bye.
Thanks.
Bye.
Bye.